The Council for Pediatric Nutrition Professionals welcomes you to this Nutrition Pearl on vitamin B12 deficiency. Vitamin B12 is a cobalt-containing water-soluble vitamin. There are several forms of B12 called cobalamins. The biologically active forms are adenosylcobalamin and methylcobalamin. Both inactive and active forms of B12 are present in foods and supplements. B12 occurs naturally only in animal foods. Some plant foods are fortified with B12. Digestion and absorption of B12 rely on several organs. In the stomach, hydrochloric acid and pepsin perform the crucial first step of cleaving B12 from food proteins. The stomach also secretes R protein, an intrinsic factor. R protein binds to B12 in the stomach and then is released from it via the action of pancreatic protease in the proximal small bowel. B12 then binds to intrinsic factor, which carries it to the place of greatest absorption, the distal third ileum. Absorption of B12 is almost all receptor mediated. Only 1 to 2% is absorbed via passive diffusion. Vitamin B12 is necessary for DNA synthesis, myelination of the central nervous system, and red blood cell production. Deficiency symptoms involve a myriad of hematologic, neurologic, and GI changes. Of note, macrocytosis is a well-known but unreliable screen for B12 deficiency. Also of note is that many symptoms may take years to emerge when intake or absorption is inadequate. Deficiency risk factors for pediatric patients include a variety of dietary intake-based behaviors, but perhaps more so, many gastrointestinal conditions and some common medications that impair effective absorption of the vitamin. To diagnose B12 deficiency, it is usually necessary to consider more than a serum B12 level, as blood levels are maintained at the expense of tissues. Additionally, serum B12 can be falsely elevated with liver disease and cancer. Low normal serum levels are still concerning for patients with risk factors or symptoms. The diagnosis is best confirmed by serum methylmalonic acid and homocysteine, elevations of which are highly sensitive for vitamin B12 deficiency. Pediatric-specific guidelines for repleting B12 are sparse. Information in this table is derived from adult guidelines, but may be safely applied to children given the non-toxic nature of the vitamin. Treatment of B12 deficiency requires high and repeated dosing of the vitamin. Repletion may be achieved via intranasal, sublingual, enteral, or intramuscular routes. Intranasal, sublingual, and enteral routes are believed to have equivalent efficacy. The intramuscular route is associated with faster resolution of symptoms and may ultimately be necessary in some patients. After treatment commences, serum biomarkers improve quickly, but symptoms may take weeks to months to resolve. Advanced CNS symptoms may never resolve, underscoring the importance of early diagnosis and treatment. Depending on the etiology of deficiency, supplementation may be needed indefinitely.